Hello, everyone. We'll get started in just a few seconds here. Wait for everybody to get into the meeting. All right. Welcome, everybody. My name is Dr. Jeff Katzman. I am the Director of Fellowship Training and Education here at Silver Hill Hospital now. Thank you for joining today's virtual grand rounds on evaluation and management of neuropsychiatric symptoms of neurocognitive disorders. I'm going to hand over the baton to Cheryl Bundy, our chaplain here at Silver Hill Hospital and spiritual counselor, just in a moment, who will introduce our guest speaker, Dr. Forrester. But first, a little bit of housekeeping. We would absolutely love to hear from you. So at the end of the lecture, we'll have some time for questions, and we welcome your comments as well. You can put in any kind of question at any time during the presentation using the Q&A link at the bottom of your screen. If you take a look and see it there. For anyone wishing to receive CME or CEC credits, please complete the evaluation survey that will automatically pop up in the browser as the webinar ends. And we will also email you a copy of the survey in case you didn't get that for some reason. For the sake of disclosures, I can confirm that no Silver Hill Hospital planners of this activity have any relevant financial relationships to disclose in relation to the presentation. And now it is my pleasure to hand this over to Cheryl, who will introduce our guest speaker.
Thank you, Jeff. It is my pleasure to introduce Brent Forrester. Brent Forrester, MD, Master of Science, is the Chief of the Division of Geriatric Psychiatry at McLean Hospital, Medical Director for Behavioral Health Integration and Primary Care at Mass General Brigham, and an Associate Professor of Psychiatry at Harvard Medical School. Dr. Forrester is an expert in geriatric psychiatry, specializing in the treatment of older adults with depression, bipolar disorder, and behavioral complications of Alzheimer's disease and related dementias. He's currently president of the American Association for Geriatric Psychiatry and a distinguished fellow of the American Psychiatric Association. Dr. Forrester's research focuses on studying novel treatment interventions to manage behavioral complications of dementia, such as agitation and aggression. Dr. Forrester also leads 2 Mass General Brigham system-wide initiatives to enhance the assessment and treatment of individuals with dementia while supporting family caregivers in primary care settings. Finally, Dr. Forrester and his research team use brain imaging techniques and careful clinical assessment to better understand the causes of dementia, depression, and bipolar disorder in later life, and to identify promising new targets for effective treatments. I'm especially proud to call Dr. Forrester a friend, and we've been friends since our college years. And I've had the pleasure of watching his career unfold. And as dementia has reached into my own family, I've been very fortunate to receive some of his counsel and compassion as my family has confronted dementia in an aging relative. It's now my pleasure to turn it over to Dr. Forrester and his presentation. Thank you so much.
Thank you so much, Cheryl and Dr. Katzman, for a really kind introduction. And it is such a pleasure to be with you all today. Cheryl, as you mentioned, Alzheimer's disease and related dementias is really affecting all of us. And although we've been through and are still living through a pandemic right now of COVID-19, I would have to say that Alzheimer's disease is about to become the epidemic of the rest of our lives. With the aging of the population and the increased prevalence of Alzheimer's disease, even if we come up with disease-modifying therapies to slow down the course, we still currently have 6.2 million Americans with Alzheimer's disease in the United States, a number expected to triple in the next 30 years, with tremendous not only burdens on patients and their families and caregivers, but also a massive economic impact in our healthcare system. So today what I want to do is talk to you about the behavioral symptoms of dementia, which really are the most burdensome aspects of Alzheimer's disease and related dementias. And before I start, here are my disclosures. We have funding through a variety of family foundations, the National Institute of Aging, and the industry colleagues who are funding some of our industry trials. Served as a consultant, and also I will be discussing the off-label use of medications for behavioral symptoms of dementia. So So I'll start with a brief case, talk about behavioral symptoms of dementia in terms of definition, diagnostic assessment. I'll briefly mention some of the non-pharmacological interventions that we utilize, some of which are not as well studied as they could or should be. Massive opportunity here. And then I'll focus mostly on pharmacotherapy and novel therapeutic interventions with some of the research we're doing. And I'll try to put this into the context of some of the risks and benefits of using pharmacotherapy, because this is an area that is frankly quite controversial, even at the level of Congress, in terms of monitoring for side effects when using antipsychotics in particular in individuals with dementia. So first, let me start about this talk with a case. So this is a gentleman who I first saw in his early 60s. And at that time, he came to me with problems with his work. He was an accountant and he was having trouble completing tax returns, and his partners even noticed it. And we evaluated him at that time for dementia. And it turned out he had Alzheimer's disease. It ran in his family with a first-degree relative, first-degree parent who had it as well, with a relatively early age of onset. Now, 6 years into the illness, or at least his diagnosed illness, he was coming in to see me with his wife, and a 2-year history of insomnia, irritability, and restlessness. And he was starting to pace, especially late in the day. And over the past week, he started to talk with imaginary people who were in his home, and his wife thought he looked more confused. He was a very healthy gentleman at the age of 67 with no significant medical problems, and was on the standard pharmacotherapy for Alzheimer's disease, which was a cholinesterase inhibitor, donepezil or Aricept, and memantine. I had started him a number of years ago on Remeron or mirtazapine at nighttime to help with sleep and anxiety. So if you think about this gentleman's case, a number of questions come to mind. And what I hope over the next hour or so is to try to help us all understand how best to address these questions. So one question is, how do you describe these or define these neuropsychiatric symptoms in the first place? And when you describe them, like agitation, anxiety, irritability, depression, et cetera, how in the world do you figure out what the causes are? Because unless we figure out the underlying cause of these symptoms, we're going to get nowhere in terms of treatment, or worse, we're going to cause adverse effects that are not necessary. So I think if I leave you with anything today, when you see behavioral changes in older adults, especially those older adults with dementia, it's very important to figure out why. It could be a primary psychiatric illness like depression, or it could be related to dementia, or it could be a medical issue. And we'll talk more about that. What are the target symptoms you want to treat? In other words, are there specific symptoms you hope to reduce in terms of frequency and severity and impact on functioning and quality of life? What non-pharmacological or behavioral interventions may help in these cases? And then if you did intervene with medicine, what would you choose? And what is the evidence base for choosing these medications? So that's what I hope to cover today. And this case sort of highlights some of the challenges when we see people presenting with these non-specific symptoms in the setting of dementia. This is a framework to understand how to approach this. So as I mentioned, neuropsychiatric symptoms are incredibly common over the course of someone's illness with dementia. In fact, if not universal, with prevalence rates of 60 to 80%, in some studies nearly 100%. But what's really important is that not just that they exist in the setting of dementia, but they're really associated with significant morbidity, a more rapid functional decline, and in some reports, even heightened mortality independent of any other medical factor. If you look at our practice guidelines that exist, and including the APA practice guidelines from 2016, which I'll mention later on, if you've got somebody who has agitation with psychosis, like delusions or hallucinations, the first line recommendation is an atypical antipsychotic medication. But what happens if you've got somebody who's aggressive and irritable and belligerent, but they don't have psychosis or they don't have depression? The experts don't even agree on what the first line of treatment should be in those individuals. And that's really the most challenging group of individuals to treat. And we'll talk more about how to approach it. Also, there's a lot of challenges when you read the literature in terms of nomenclature. Some people refer to this illness as the behavioral and psychological symptoms of dementia, known as this acronym BPSD. But we don't have established standards for what medications to use or non-pharmacological interventions to use. It really is a highly individualized approach. And then finally, and as I mentioned before, every single medication that we use for these individuals with dementia behavioral symptoms is completely off-label. There's not a single drug approved by the FDA for any of this, which is important to know because when we give informed consent to family members who are serving as healthcare proxies for their loved ones, or even for individuals themselves, if they can provide consent, they have to understand this is off-label treatment. So as I already mentioned, the first thing we need to think about is definitions. How do we even think about these syndromes? So my colleagues, Dilip Jesti and Sandy Finkel, real pioneers in the field of geriatric psychiatry, and frankly, with Dilip's case, psychiatry in general, they coined the term the psychosis of Alzheimer's disease, which appeared in the research category of the DSM-4. But this is the definition that's being used currently by pharmaceutical companies to try to get a drug indicated. But if you look at the literature, you'll see lots of different definitions that are used. You see the neuropsychiatric symptoms of dementia, you see the non-cognitive behavioral symptoms of dementia, or this acronym BPSD. But what's important to remember is that this includes a massive range of symptoms. Frankly, we see in lots of other psychiatric conditions, everything from anxiety to agitation and aggression, to wandering, to repetitive vocalizations, to depression or mania, to frank psychosis, including delusions and hallucinations. And defining what these symptoms are is very important so that we know what it is that we're going after in terms of treatment. This slide highlights the three major domains in terms of drivers of these behavioral and psychological symptoms. So I break them down into three buckets: the medical bucket, the psychiatric one, and the environmental one. So first, the medical. So anyone who presents with psychiatric symptoms who are older, the first thing I ever learned in my training about behavioral symptoms in older adults, period, but especially in dementia, is what are the medical causes of these symptoms? It could be a UTI. And frankly, during the pandemic, it could have been COVID-19. In fact, we saw this quite a bit. I'm sure you all did as well. Older adults presenting not with fever and respiratory symptoms, but with a change in mental status, with confusion, with inability to attend to stimuli around them, or even hallucinations and delusions. So physical, medical causes of behavioral symptoms really important. Again, constipation, pain, medication side effects, drugs of abuse, all of this under the bucket of medical. Then there's the environmental, really important. And every single individual, no matter what we do to understand the medical and psychiatric causes, we have to think about what's going on around the person. Is it the burned out, stressed out caregiver who's losing their loved ones in terms of dementia? They're seeing memory problems. They don't understand what's going on. They're very exhausted and overwhelmed themselves. They start to escalate in confrontational ways. And before you know it, there's aggressive outbursts. So it could be something happening in the home environment, in a long-term care or hospital environment, but look at the precipitants to the behavioral symptoms. And there may be cultural issues as well. And then finally, very importantly, psychiatric. And by this, I mean, really important in all of these individuals, whether they have dementia or you're not sure if they have dementia, is get a good sense of their previous psychiatric history. And there are many reasons for this, but let me give you an example of why this is so important. So when I first finished my fellowship, and I was up in New Hampshire at the time at Dartmouth, I was working in a community mental health system in Manchester, New Hampshire, and I was the consultant to a local nursing home. In that nursing home, they had a dementia wing, which is pretty common. And I was asked to see a woman who had just been admitted from a local general hospital after a one-week stay for a syncopal episode where she passed out at home, was brought to the hospital, found to be dehydrated. And while she was being evaluated, they did an MRI of the brain because she appeared quite cognitively impaired with limited speech, and she had frontal atrophy. And they diagnosed her with frontotemporal dementia, or Pick's disease. And she was admitted to the nursing home for end of life palliative care, essentially. I was asked to see her because she wasn't cooperating with activities of daily living care. She was not engaging in activities on the unit. And frankly, she was extraordinarily cognitively impaired and not adhering with medications. When I went to see her, she was standing in the middle of the hallway. And the first thing I noticed is she was 30 plus years younger than everyone else. She was 54 years old at the time. Everyone else, average age of 85. That was strange. The second thing that was a little unusual was she was completely mute. I mean, she had no verbal expression whatsoever. She had no facial expression either. And when I went to do a brief neurological examination and I shook her hand, she kind of left it up like this. So if we were in the same room, I might pick on people and say, what do you think that is? Well, that was a sign of catalepsy, which we see as a manifestation of catatonia. And I thought, this is strange. Now, what's going on here? And so I looked at her medical record. There was no mention of any psychiatric illness. So I called her husband and I said, Bob, what's going on with your wife? And he said, well, we've been married for 30 years. By the way, she has bipolar disorder. And she was doing pretty well. She's had recurrent episodes of mania and depression over the years, but was doing well in medicine and raised our 3 kids. And now for the past 3 weeks or so, I thought she was just getting depressed. She was getting quieter like she often does. But this time she really didn't want to eat or drink anything. And she passed out one day. And now they tell me she has end-stage dementia. And I said, well, Bob, I think what your wife may have is a severe manifestation of her psychiatric illness we call catatonia, and we got to get her in the hospital. And so we had her admitted to the hospital, and she eventually had electroconvulsive therapy or ECT. And she got better. And she went home and she became my outpatient for the next 5 years while I remained at the mental health center. And, and they were very thankful that we saved her life. And so I learned a lot from this situation. One thing I learned is when someone is psychiatrically quite ill, whether it's depression with psychotic features or mania or acute psychosis, it's very hard to understand or evaluate their true cognitive baseline. In the setting of a psychiatric illness like that, it's very hard to know what their cognitive baseline is. Second thing I learned is that what you read in a medical record may be wrong, or more likely than not, and in this case, it's just incomplete. No one had bothered to speak to the family to get a good history. That was critical. And then the third thing is, especially for you trainees out there and for other people who are early on in their careers, what you read about in terms of a diagnosis may not be the full story. And if something doesn't add up, like it didn't in this case, she was younger, she looked like she had catatonia, which is not a common thing in dementia, but is a common thing in certain psychiatric illnesses, don't be afraid to reassess the clinical situation and make a diagnosis for yourself. So anyway, keep that in mind as we go through the talk. Etiology of medical psychiatric conditions and environment. Now, my colleagues, Helen Kales and others at the University of Michigan, put together this wonderful approach, which is really a systematic way to assess these behavioral symptoms of dementia. And it's called the DICE approach. Again, there's nothing that I'm going to tell you here is rocket science, but it really is not done consistently. We often will throw medicines at people because they're acutely agitated to calm and make the situation safe now without thinking about the full picture. So here we want to describe the symptoms like we talked about, context, the environment, the provoking factors. We want to investigate the medical etiology, the social etiology, caregiver issues, and so forth. We want to create a treatment plan that includes both non-pharmacologic behavioral approaches and pharmacotherapy when indicated, and then evaluate the response. Let me just say one other thing about evaluation. I will say that those of us in the field of psychiatry, for the most part, are not very good at collecting systematic data on the patients we're seeing. You wouldn't go to an internist and get prescribed a blood pressure medication without following your blood pressure, or being given an oral hypoglycemic agent for diabetes without following blood sugar or hemoglobin A1C. And yet all the time we prescribe psychiatric medicines without collecting objective data on severity of anxiety, depression, mania, psychosis, you name it. I will just say that our colleagues in primary care, because of the re-engineering of healthcare systems and risk-based contracts and ACOs, are frankly routinely collecting the PHQ-9 for depression. Now, some of us will do this in certain psychiatric settings, and we're getting better at it. But I think in this case, having some objective measure of severity of symptoms is critical. Now, I will say, having tried to implement these measures in standard clinical settings, it's way easier said than done. But think about this in terms of the clinical practice that you all have. Like I said, this is not a talk about behavioral interventions, in part because these treatments are not as well developed or studied, frankly. And if I had to say like the one key thing to remember here is that one size does not fit all. It's really not, a specific approach that will work for a group of individuals. It's a specific approach that works for that specific individual. So it may be that, exercise works, or attention to the environment and the way in which a caregiver is changing their loved one during ADL care, or showering them, or dressing or bathing them. And it may be the environmental approach of noise. Think about a long-term care or hospital setting. At the time of sundowning in the late afternoon is when we have a change of shift. And if you have somebody with dementia on a unit that's not really equipped to manage people with dementia, they're not going to think about the noise and the chaos of a change of shift and how that might impact behavior. Anyway, there are a lot of interventions, but one that really works well and has been pretty well studied is exercise. And this is an old study now, almost 20 years old in JAMA, but essentially it was an outpatient study of 153 caregiver patient dyads. And essentially this exercise intervention plus caregiver training, when compared to whatever usual care was, improved physical functioning and reduced depression. at 3 months. And after 2 years, there was actually a improvement in physical functioning and a trend towards reduction in nursing home placement. And these depression symptom outcomes were retained for 2 years. So again, this was one small study. There's been lots of data, frankly, on the beneficial effects of exercise on brain health, may even help to reduce the risk of dementia. It certainly helps to ameliorate some of these behavioral symptoms. And again, all of these non-pharmacological interventions have not had the pharmaceutical industry behind it funding these kinds of studies. And I'm hoping with the advances in federal funding for Alzheimer's research at the National Institute of Aging level, we're going to see better studies coming out in the near future. So what I want to focus on for the majority of the rest of the time is how do we think about these pharmacotherapy approaches? And then I'll talk about the research that we're doing in the bottom here with cannabinoids and ECT. Most of the work that I'm going to present to you today is on the use of antipsychotic medications. And the reason for that is, number one, they're the most widely used. Number two, they're the best studied. And number three, they are highly controversial in this population. And the controversy essentially goes back to 1987. And in 1987, the federal government passed a law, the Omnibus Budget Reconciliation Act, or the OBRA guidelines, which were the first attempt to regulate the use of psychotropic medications in nursing homes, not in assisted livings, not at home, not even in hospitals, in nursing homes. And that was because CMS, the Center for Medicare and Medicaid Services, is funding a large majority of care in nursing homes, Medicaid in particular. And what they were finding, and we were finding back in the 80s, was the use of conventional antipsychotics like haloperidol, which were essentially leading to severe sedation and Parkinsonism and tardive dyskinesia with no regulation whatsoever. So that was the first, and now what's a series of guidelines, the most recent, the CMS guidelines that continue to be revised, but essentially regulate the use of psychiatric medicines now across the board. So we'll just keep that in mind, those sort of policy issues and the impact it has really on clinical practice as we go through what the clinical evidence and research is. So this slide, for those of you who are well-trained, who have been in psychiatry for your careers, may say to yourself, well, why do I need to know a basic definition of psychosis? Well, I'll tell you one thing. We throw the term around psychosis or psychotic disorders all the time in psychiatry. And when you're talking about older adults, if you do that, you forget about etiology or cause. So we know that psychosis, for example, is defined as an impairment in connection to reality. It can include auditory, visual hallucinations, paranoid delusions, and so forth. But psychosis is a symptom, or maybe a syndrome. It's not a diagnosis. Like, for example, you would never say somebody has a cough disorder. You would say they have a cough, and it might be due to allergies or pneumonia or COVID-19 or cancer. But the cause is critical because the treatment is vastly different, as is the prognosis. Again, this seems so basic, but when we see psychosis in older adults, let's make sure we take a step back and not say they have a psychotic disorder, but say, they're seeing things that aren't there. Why is that? Well, they might have schizophrenia for the first time at the age of 65, but that's extraordinarily unlikely. They might have mania for the first time at 65, and this, if they've got manic symptoms plus psychosis, but that's also not very common. What is really common is dementia, and what is really common is delirium. Those are the two most common causes. So again, the manifestation of psychosis for the first time in older adults should beg a significant workup of medical causes, neurological causes, and so forth. The other thing that's really important to remember is when you see older adults with dementia who develop delusions, they're generally not like the delusions we see in people with schizophrenia. They're not bizarre delusions like stories of aliens invading their eyebrows or reading their mind. Those paranoid delusions of a bizarre nature are not what we see in people with delusions in Alzheimer's disease. What we see there instead are delusions based on someone's inability to remember, like, where did I put my pocketbook? Or this is not my house and I don't recognize my spouse. So they may think that their spouse is an imposter, or Capgras syndrome, delusional misidentification. Or they may think, like the first ever patient that Dr. Alzheimer's evaluated in 1906, Auguste D., she had, at the age of 54, delusions of marital infidelity along with cognitive impairment, and on autopsy had evidence for plaque and tangle pathology of Alzheimer's disease. So the working diagnosis indicates duration of treatment. So if you've got Alzheimer's disease and within a few weeks you develop visual hallucinations and agitation, and someone does a urinalysis and you've got a urinary tract infection, well, you might need to use olanzapine or risperidone or one of the antipsychotic medications to treat that to treat the agitation and the paranoia. But those medications won't treat the underlying infection. You have to use antibiotics. So it's not that you wouldn't use antipsychotics, but you got to figure out the underlying cause. And then if you do use antipsychotics, you probably don't need to keep the person on the medication for months and years, because it's often due to this acute illness of a UTI. Now, the older drugs, which I've already alluded to, the OBRA guidelines, but medications like haloperidol and perfenazine, thorazine, et cetera, the conventional antipsychotics, both high and low potency antipsychotic medications. The issue here is not lack of efficacy. There is some efficacy. The issue is toxicity. In the manifestation, the toxicity is Parkinsonism, tremor, rigidity, falls, masked faces, and so forth. And tardive dyskinesia. If you look at somebody in their 30s with schizophrenia who go on haloperidol for a year, the 1 year incidence of tardive dyskinesia is about 5%. And it goes up by about 5% every year, so that after 3 years, it's about 15%. Now that same person with schizophrenia is 70 or 80, but it's an older adult. That risk of TD in the first year is nearly 30%, 50% after 2 years, 2/3 after 3 years. So the rising risk of TD is associated with advancing age, female more than male, and mood disorders more than psychotic disorders. But for the purposes here, it's an age issue. There also may be a differential increased risk of mortality when using the conventional agents for the psychosis of Alzheimer's disease. But the FDA has only put their warning out, and I'll talk more about this in a minute, for the entire class together. In the 1990s, for those of you practicing psychiatry at the time, and that's when I was coming of age in my residency in the early 90s to mid 90s, the atypical antipsychotics were coming onto the scene. Clozapine was in 88, and risperidone was in 1993, and so forth. Olanzapine in 1996. Now, when I ask residents this question, is there any data to support the use of these drugs in Alzheimer's disease? Most people say, no, there can't be any data. Turns out there's a ton of data. And the reason for that is that back in the 90s, the pharmaceutical companies saw a massive opportunity. They saw a rising age of the population, increasing people with dementia in long-term care, lots of behavioral symptoms, safer drugs, right? From a metabolic standpoint, maybe not, but from a tardive dyskinesia standpoint, maybe yes, in using the atypicals versus the conventional agents. And so they did a lot of research in this area. So I'm going to first show you an example of a study that was done with the older drugs, but these dosing ranges for olanzapine, risperidone, quetiapine, aripiprazole, all of those are not made up or based on clinical practice alone. These are based on dosing ranges that were defined from evidence-based randomized controlled trials in people with dementia. Some of the newer medications, not clozapine, but the other newer medications, there's very little information in terms of outcomes, safety, efficacy, and so forth, with two exceptions. Brexpiprazole, which is Rexulti, which has been on the market for a number of years, is now being looked at for the treatment of the psychosis of Alzheimer's disease. There's been 3 studies, two completed, one ongoing, and one positive, one negative. So we'll see, the jury's out on that drug. I've never used that drug in this population, in part because the newer medications are so hard to get approved in terms of cost, insurance. Pimavanserin, which has been approved for well over 5 years for the psychosis of Parkinson's disease, recently applied to the FDA for the first ever drug to be indicated for the psychosis of Alzheimer's disease. And exactly 6 weeks ago or 7 weeks ago, the FDA rejected their application based on lack of efficacy on their primary outcome measure. So the company is taking a step back and having further conversations with the FDA to see if there's still a pathway forward with another trial or with a reinterpretation of the data. But so we'll see. It could be that pimavanserin becomes the first drug approved for this indication. We just don't know. Now, as far as tardive dyskinesia goes in this population, risperidone and olanzapine, for example, it's not like you can't see tardive dyskinesia, but the rates are much less than they are in younger adults. So instead of 28% in year 1 with haloperidol, it's around 5% per year, or 6.7% with olanzapine. So this study, which is now published, believe it or not, 22 years ago, was the first ever study published with the use of an atypical antipsychotic in dementia. So I want to highlight a few key things about this study so you understand the difference between how these pharmaceutical funded studies were done versus what I'm going to show you in a minute, which is the CATIE trial for Alzheimer's disease, funded by the NIMH. In these studies, they were done in nursing homes or hospitals for a short period of time, 6 to 12 weeks. They had people with advanced dementia, with mini-mentals in the single digits or low teens. They generally had a primary outcome measure that was a symptomatic reduction on a certain rating scale. This particular study happened to look at the psychosis subscale of the behavioral rating scale in Alzheimer's disease to see if it impacted hallucinations and delusions. Finally, they looked at drug versus placebo. In this study, they looked at 3 different dosing ranges. They looked at 0.5, 1, and 2 versus placebo. And what they found after, again, this 12-week study was an improvement at 1 and 2 milligrams a day. So up is good here, but you see marginal effect size going from 0.5 to 1 and no further beneficial effects going from 1 to 2. When you do go from 1 to 2, though, you double the rate of extrapyramidal side effects. So that what I showed you before here, this dosing range of 0.5 to 2 really comes from studies like this. There were 5 of them. There were 5 risperidone studies for Alzheimer's disease. And they showed similar findings where you go from 1 to 2, there's no evidence of efficacy advantages, but there is more extrapyramidal side effects. So those dosing ranges you see there, all based on trials like this. So now I'll compare this trial with a CATIE trial. Now, those of you who have been practicing psychiatry for a while will remember that in the 90s, the NIMH decided to embark upon numerous real-world, what were called effectiveness trials in psychiatric conditions. So there was the STAR-D trial for depression and the STEP-BD study for bipolar disorder and the CATIE trial for schizophrenia. Well, many people don't realize it, but the CATIE trial had 2 sub-studies. They had the schizophrenia study and they had the Alzheimer's study. When I was up at Dartmouth, I was involved as a principal investigator in the Alzheimer's study, and that's what this was. 42 sites, double-blind trial, relatively small number of patients, 421. These were not in nursing homes, not in hospitals. They were outpatients or in assisted living. And they had Alzheimer's with either psychosis, agitation, or aggression. And instead of following people for 6 weeks or 12 weeks, they were followed for 9 months. And they were randomized to 3 arms, 3 drugs or placebo. Now, the doses that you see here are the doses that the drug got to before, at a mean dose, before they were switched from the phase 1 to phase 2. And the way the study worked was the investigator, like me, was given a patient who was randomized to either 1 drug or placebo. And they were outpatients. They were highly symptomatic, and we were quick to switch. So we were allowed to increase the dose. We didn't know whether they were on drug or placebo. And they got to a therapeutic dose of olanzapine and risperidone quicker based on the study escalation parameters than they did with quetiapine. So again, if I were in person, I would ask for a show of hands, to see who, which group, you thought did best. But essentially at the end of the day, when you look at the outcome of discontinuation, there was no drug placebo difference. And the definition of discontinuation is like, why would a clinician stop a drug? Well, you stop a drug because it's either not working or it's causing problematic side effects. That's a real world outcome that matters, right? But it doesn't really say anything about symptomatic reduction of psychosis or agitation. So when you break that down, what you find is that if you look at a secondary outcome of efficacy, which is symptomatic reduction in hallucinations, delusions, or agitation, you see risperidone and olanzapine perform better than quetiapine and placebo. You stayed on the drug longer if it was working. Not surprisingly, the reason why this is a negative study is because placebo is so much better tolerated than any of these drugs in people with dementia. What I think is very interesting about this slide is that if you look at 3 categories where we really worry about drug placebo differences, falls, stroke, and deaths, there were none. Now, you could argue the sample size was small, 421 people. So to see a drug placebo difference, you might need to see a higher dose. You might need to see the patient on not only a higher dose, but you might need to see them on higher dose for a longer period of time. But in this study, placebo did better because they also were dealing with a healthier population. These were patients who were not in nursing homes. They had higher mini-mental status exam scores. And that may have been why the stroke death difference was not seen here. So this study came out in 2006, and there was generally a concern that there was not only a lack of efficacy in symptomatic reduction, but there may be some safety issues. So what's happened since then? Well, one question that was not answered by that study was, well, what do you do with somebody who did better on the drug, right? So you put them on risperidone for 4 months and they get better. Like, when do you stop the drug? Deb Devanon, my colleague at Columbia and colleagues, did this study, published in the New England Journal now almost a decade ago. After 4 months of open label risperidone, get the patients better, half stay on drug, half taper off. What happens? Well, 4 months later, 2-to-1 ratio of relapse in the placebo versus the drug group. And then over the next 4 months, it's like 3-to-1. So even though the experts all recommend, and the APA guidelines I'm about to show you recommend discontinuation of drug after someone is stabilized, antipsychotics, to minimize the risk of side effects, it's easier said than done in terms of the risk of relapse. The reason why this area has become such a political football, hot potato here, is because of the risks of stroke and mortality that came out of an FDA meta-analysis back in 2005. First, let me say something about strokes. There was a study that was published in 2003 with Henry Brodati in Australia that showed that people on risperidone versus placebo in these Alzheimer's studies were showing a higher risk of stroke-like events. Big strokes, small strokes, they lumped it all together. But regardless, for these three drugs, not quetiapine, there was a 2 to 3-fold increased risk of cerebrovascular adverse events. Not necessarily related to death, but related to just having the stroke-like events in the first place. Quetiapine, interestingly, seemed to have the opposite effect. Again, lower sample size numbers of 568 versus much higher numbers with the other three. But regardless, quetiapine seemed to not cause strokes or stroke-like events, but may be associated with the lower risk. Why that would be is anyone's guess. The real issue here was the mortality warning that was published now 16 years ago by the FDA. So what they did was they took all those pharmaceutical company funded studies and they did a meta-analysis of 17 trials enrolling over 5,000 people with dementia-related psychiatric symptoms, 2/3 on drug, 1/3 on placebo. And the rate of death in the drug-treated patients was 4.5% versus 2.6% in placebo. So about a 60 to 70% increased risk of death, so significant. Now, the overall numbers differential between the two is relatively small. And one question that came up from almost everyone was, well, why were these people dying? What was the mechanism? And we don't know for sure, of course, because there were no autopsies done in these studies. But when the clinician was forced to write a cause of death in these clinical trials, the two common complications that were listed most frequently included infectious and cardiovascular. So why might that be? Well, infectious. So if you treat somebody with a sedating medicine like risperidone or olanzapine, let's put it that way, or haloperidol, it could lead to sedation, aspiration, pneumonia. That might be one cause. And we know that the antipsychotic medications increase the QTc interval on the EKG and put people at risk of sudden cardiac death from cardiac arrhythmias. So we have to be very cautious about these two possible causes. What I often will tell patients and families to watch out for is I warn them about the risk of death and stroke, but what I really focus on is what could happen early on. This is true for pharmacotherapy for older adults, period, but especially in dementia, which is that for antipsychotic medications in the first few weeks, what you're looking for are side effects of sedation, orthostatic hypotension, where people drop their blood pressure when they stand up fast, or gait disturbance, where they have gait instability and risk for falls. Those are the three things we watch for early on. That's most important. These are not important, but their risks are lower and their longer term effects, longer term 6 to 12 weeks, not the few days to a week or two. Now, thankfully, our APA came out with practice guidelines 5 years ago that are very reasonable, frankly, and I would not disagree with most of them, with one exception, perhaps. And that is that the antipsychotic should only be used in people with dementia if the benefits outweigh the risks. That's not controversial. Starting low and going slow is not controversial. Risks and benefits have to be reviewed. If they're not getting better after 4 weeks, start something else. But here's the issue, is the middle one. If there's adequate response, attempt to taper and withdraw the medication within 4 months of initiating treatment, unless you've tried this before and people relapse. So what if you've done this for the first time and someone was in the hospital and very psychotic and agitated, and finally you found a drug to work? And from the Devanon study, the risk of relapse is considerable. This is where I think you really got to take it on a case-by-case basis. And I don't think any of the regulators and nursing homes would argue If you say how sick they were to begin with, you put them on a medicine, they got better, and now the risk of withdrawal is considerable, and they're not having side effects. So that's something that I think you just need to document. Otherwise, I think these practice guidelines, which by the way are over 200 pages, this just sort of provides some of the highlights, are really helpful. When the warning came out in 2005, there was a lot of worry that clinicians were going to overreact. And at the time the warning came out, the warning was only the atypicals. It wasn't Haldol. Now it's for the entire class of antipsychotics, the older drugs, the newer drugs. So don't overreact by prescribing benzos, that's for sure. We'll talk more about benzos in a minute, but sedation, gait disturbance, worsening cognition, the chance of disinhibition, not a great choice. Even though people may get better within a few hours or a few days, the cumulative risk is considerable. I think what's most important is to get back to the basics. What was causing the behavioral problem in the first place? Maybe a medicine's not even needed. Maybe it's a behavioral intervention. Maybe it's an environmental adaptation. Maybe it's caring for the caregiver that's needed more than anything else. Always employ these behavioral interventions, no matter what you do with medication. And then when using antipsychotics, we can use them. There's good evidence base, but please give informed consent and make sure families, healthcare proxies, guardians understand the relative risks and benefits. I mean, at the end of the day, we're trying to balance side effects with efficacy. All right. Just a couple more comments about pharmacotherapy. One clinical syndrome I want you to think about is mania in older adults when it's due to an underlying medical or neurological problem. And we call that secondary mania. So if you evaluate a patient who's never had any behavioral problems in any psychiatric history, they're now say 55, 60 or older, and they're developing symptoms that look like mania, it's most likely not idiopathic, new onset, family history risk bipolar disorder, more unless they've had recurrent depression, because that's in people with recurrent depression, you can see mania not uncommonly first presenting, not in their 20s, but in their 40s and 50s. But when you see it with no prior psych history in particular, think secondary mania. The reason I'm mentioning this here is partly for the evaluation piece, but it's also for the treatment piece. If you think about mania due to dementia, you see poor impulse control and disinhibition and mood lability and aggressive behavior. And it's not unlike mania we see in younger adults. So using mood stabilizing anticonvulsants like divalproex or gabapentin or others may be reasonable, and there's just not a lot of data to support their use. And if you look at divalproex, which is Depakote, which is the best studied in dementia patients with agitation, and in one case in secondary mania, all the studies were negative, except when you started to look at their secondary outcome measures. And there's the issue here with tremor and gait disturbance and risk for falls and so forth. But the SSRIs may be an alternative treatment option for non-specific agitation, maybe not for psychosis, but for agitation, not depression, agitation, again, verbal or physical. And this is supported by the well-known CTAD trial, or CTAD trial. It's citalopram versus placebo in Alzheimer's disease. 186 people, psychosocial intervention with and without medication, dosing up to 30 milligrams a day with an improvement on various outcome measures of agitation. Importantly, with citalopram in older adults, we know there's a boxed warning for younger adults as well when you go above 40 milligrams a day for depression or anxiety. But in older adults, you know, the dosing range is lower. You're not supposed to go above 20 a day. And in this study, when you got to 30 milligrams a day, the risk-benefit ratio swung towards risk. So I would say with citalopram or any SSRI, if you're going to use it for agitation and dementia, you're going to want to start at a low dose, go slow, and for citalopram, probably 20 milligrams a day is the target on average. So let me, with the time we have remaining, and we've got plenty of time, by the way, for questions and answers and all, but for the time we have remaining, let me talk about some of the research we're doing at McLean that I've been involved with now for almost 2 decades with ECT and for probably about 15 years with cannabinoids. So let me tell you about this patient that we treated now nearly 18 years ago. Her name was Louise, and I tell you her name because her daughter, Karen, has been very open and outspoken about her mom's case. In fact, she's written letters in support of our research to the NIH, and she's also appeared on NPR and other programs to talk about, you know, their family's experience with this. But at the time I met Louise, she was 67. She was already a decade into dementia. She had been diagnosed a decade earlier with neuropsych testing, MRI scans at Mass General Hospital. She had had 8 years now of hippocampal atrophy on her MRI. And she was now essentially nonverbal. And the reason she was in the hospital with us was not because of her poor memory or nonverbal nature. It was because she was aggressive, and she was agitated and aggressive and frankly dangerous towards her husband at home. And she'd failed numerous medications, both before the hospital and during the hospital. And anything we tried essentially either sedated her, caused her to fall, or just didn't work. And so a colleague of mine, Dr. Stolier, who I still work with, thought it might be a good idea to try ECT. And I said, Alex, why would you consider using ECT in somebody who's severely cognitively impaired like this? It might worsen her memory. He's like, why does it matter if we worsen her memory? Her mini mental is already 0. Her agitation is the issue. Her aggression is the issue. And there are cases in the literature at that time. There were some case reports that it might be effective. And so we did. And 2 months into the hospitalization, she received her first ECT. Her husband consented. We decided at that time to implement bilateral treatment. She received 8 treatments, and her improvement was quick and dramatic. And she essentially remitted in terms of her agitation and aggression. Now, of course, her cognitive functioning was still quite poor, though she was able to speak a little bit. She was calmer. She was cooperative with ADL care. Her appetite improved. Except for a headache, there were really no major side effects. And she left on 1 medication, Lexapro, escitalopram, and PRN haloperidol was used for agitation, which was never used when she went home. And what's remarkable about this case was not only the acute improvement, but for the next decade, she came back to McLean every month for maintenance ECT. She was brought here faithfully by her husband, and she passed away 5 years ago from metastatic cancer, 20 years after her original diagnosis, and many years of living with a better quality of life. And so when we treated Louise and a series of patients like this, we started to notice this remarkable improvement. And at the time, a lot of us get upset when the Joint Commission comes to visit our hospital and all the hoops we have to jump through. Well, the Joint Commission was visiting McLean around the time we started doing this work. And one of the astute nurses on the JCO team said to our president and psychiatrist in chief and my mentor, Bruce Cohen, Bruce, they're doing some interesting work with ECT on your units. You guys should study it. And so he said, Brent, you should study it. And so we did. And so this just describes, the first thing I'll just say is that the daughter's words were quite powerful, frankly, and helped support future grant opportunities. But I'll just read this to you. Karen said about her mom, my mother was a petite 5'3", 115-pound terror when her aggression reared. She was uncontrollable. Her medications were losing efficacy, and it became so dangerous for our in-home aide and my dad and I that we had no option but to place her inpatient at McLean. From that very first ECT treatment, the medical teams, my father and I, were essentially rendered speechless. Walking down the hall after that first treatment, she came at me like she used to and aggressive, but this time she reached her arms out. She rubbed my cheek lovingly with a smile from ear to ear, and tears rolled down my cheeks. And behaviors that we thought were once robbed long ago returned. And my mother was using words and sentences instead of gibberish, and her agitation and aggression nearly went away. And she went from 31 medicines to 1, and we were able to bring my mom back home, and we're blessed with another 10 years of her life. This treatment gave my mother tremendous quality of life and quality of care. It gave my father, his wife, and me, my mother. And without ECT, she would never have seen me get married. So we published 2 studies from our original work. One is not shown here. That was a retrospective case review where we saw a reduction on a rating scale called the Pittsburgh Agitation Scale. And on this one, we decided to recruit another site, Pine Rest Christian Mental Health Services, another psychiatric standalone hospital, not unlike Silver Hill and McLean, based in Grand Rapids, Michigan. And my colleagues there, Eric Achtes and Lou Nijkamp and others, really were instrumental in helping us collect this data prospectively. So we thought we were being clever. We thought that instead of creating a research study that would require an IRB to randomize people to 2 different treatment arms, we decided what we would do is we would collect naturalistic data. And the IRB protocol was just about approval to ask questions of patients and caregivers about how the person was doing. It was not about ECT. So they were basically recommended to receive ECT, and we got consent to collect data. And our primary outcome measure was the Cohen-Mansfield Agitation Inventory. And what you can see here is that in our study sample of patients who had a mean age of 74, highly educated, mostly women, 14 out of 23 were women. All were Caucasian. This, by the way, is a huge issue, not only across the board in psychiatry research, but in dementia research in particular, is the lack of representation from minority populations based on race and ethnicity. It's an area that we're trying to desperately, address. But in any case, and about half had the Alzheimer's type of dementia with clinical diagnosis. And interestingly and importantly, they were in the hospital a mean of 4 weeks before they got their first ECT. So we saw essentially a reduction in ECT beginning by the third treatment, which was a week of treatment, which continued and improved through the third, sixth, and ninth, and a little bit further through the 12th. We saw the biggest effect between really at the sixth treatment mark and continuing into the ninth. So when we designed a prospective study, this was the outcome measure we used, and this was the timeline. After many attempts at getting funded, we finally received this grant a couple of years ago. This is a 5-year study, NIA-funded, randomized trial. And we decided that the only way we could randomize people to a control group was to create a new intervention that we're calling simulated ECT. It's not sham. We do not give people anesthesia. What we do is we randomize people to these two arms. And if you're randomized into simulated ECT, your inpatient treatment team is kept blind to treatment allocation. You're brought down to the ECT suite by a clinician, a nurse's aide. A research assistant is with them as well. They spend an hour in the ECT suite. They're given an IV with no anesthesia. They can use PRN medications orally or intravenously if needed for agitation control. That information is documented, but the ECT treatment is not in the electronic medical record. It's kept separately with the ECT team and they're brought back to the unit. The goal is 9 treatments over 3 weeks with an open label extension for a year in these 5 sites around the country, with the University of South Carolina being our data coordinating site. But Northwell Health with my colleague and North Shore LIJ with my colleague George Petrides, Pine Rest, McLean Mayo Clinic, and Emory. This has been the biggest challenge I've had in my entire career in terms of launching a research trial. Not only did we have COVID to deal with, as everyone has, but we also had the FDA to get approval to get an investigational device exemption for ECT and an off-label use, not depression, not catatonia, but for agitation and dementia. And then we've, of course, had recruitment concerns that have been very difficult and challenging, which I'm happy to talk more about. The other major area of research interest for us in terms of therapeutic interventions in this population are cannabinoids. So there are 3 cannabinoids on the market, but the one that's most widely used and known in this country is called dronabinol or Marinol. It's a scheduled drug. It's approved for anorexia in patients with HIV, and it's given for people on chemotherapy for nausea and vomiting. There are 2 major CB receptors, cannabinoid receptors. The CB1 receptor mediates the anxiolytic effects of THC, whereas the CB2 receptor mediates putatively these anti-inflammatory effects and may also have anti-amyloid effects, by the way. And in the short term, we were interested in taking advantage of its effects on calming people down and being wary of euphoria or elation, or even the induction of inducing psychosis. So similar to the ECT study, what we first did was our clinical observations on our inpatient unit. We collected a case series of 40 inpatients with dementia, complicated by agitation, on dronabinol up to 10 milligrams a day with a mean dose of 7. Looked at reduction in the Pittsburgh Agitation Scale, which includes, reduction in resistance to care. Very well tolerated with no adverse effects leading to stopping the drug. And the side effects that we saw are listed here. This pilot data alone led my colleague, Dr. Rosenberg, and I to write a grant to the NIA that got funded a few years ago to study dronabinol in people with dementia and agitation. It's a 5-year study. We're actually in year 5 as we speak, comparing 3 weeks of dronabinol with placebo, looking at the NPI-C as our primary agitation outcome measure, and looking at safety. So far, we've recruited over half of our sample. These numbers are about 6 weeks old now, so we're just at about 50. Again, mostly a 73% women population, highly educated, severe agitation on the NPI-C for agitation, not delirious. We exclude people with delirium, but they're quite cognitively impaired as well. So more to come on this study, and hopefully in the next couple of years, this will be wrapped up. Now, a number of years ago, I met a gentleman by the name of Greg Spire, whose father had Alzheimer's disease. Greg was interested in being supportive through his family foundation of research in Alzheimer's disease. They funded us for a few studies, but one that they funded recently was based on his experience with his dad, where his dad had essentially terminal agitation in the setting of dementia, was living in Florida at the time. And a family member, this is before medical marijuana or cannabinoids were more widely available in retail settings. But essentially they used medical cannabis with a dramatic improvement in behavioral symptoms. And so he funded us to do something similar. But instead of looking at medical marijuana and high THC products, we decided to look at CBD for a variety of reasons. And I am partnering with my colleague, Dr. Stacy Gruber at McLean, who is the investigator leading the Mind Center. This is really innovative research she's been doing in adults with anxiety disorders, and we've partnered together to use similar protocols for the Alzheimer's population. So here we're using CBD mostly. It's essentially 45 milligrams of CBD with about 1 milligram of THC. It's essentially classified as industrial hemp, which means that we don't have to go through the same rigorous approval process and when you're using THC compounds. It's an 8-week open label trial with only 12 patients, a custom formulated high CBD, low THC, full spectrum, plant-based solution that's delivered sublingually to treat anxiety and secondarily agitation in people with Alzheimer's disease. So more to come on that. We just, by the way, completed our first subject a few weeks ago with, again, it's open label, so hard to know, but the effects were quite notable and seem to have dissipated, frankly, as she's come off the medication, even though we've switched her to another product that's, again, commercially available. I already said why not to use benzodiazepines. I won't belabor the point. Again, they may work acutely, but over time will cause more problems than not. Now, don't forget that the drugs that we have to treat the cognitive and functional symptoms of dementia, the cholinesterase inhibitors that increase acetylcholine neurotransmission in the brain, drugs like Tacrin, no longer on the market, or donepezil, Aricept, rivastigmine, galantamine. These medications not only slow decline for a period of time, but they actually help to improve certain behavioral symptoms, including apathy, most prominently, and visual hallucinations. So if you got somebody with Lewy body dementia who presents with profound visual hallucinations and secondary agitation, where you want to avoid antipsychotics because it will make Parkinsonism worse and it might make them delirious, cholinesterase inhibitors are the way to go. Rivastigmine in particular, which has been approved for and used in widely Parkinson's dementia, may also work for Lewy body dementia. So at the end of the day, I leave you with 4 sort of clinical scenarios and the pharmacotherapy approaches you might want to consider based on the evidence we reviewed and decades of clinical experience on my end. If you got somebody with Alzheimer's disease who's mildly anxious, who's not physically aggressive, who's not pacing or yelling or maybe wandering a little bit, but they're not dangerous in any way. And they may be having sleep problems and perhaps they may have mild anxiety symptoms as well. But that's where you would start with an SSRI, like citalopram or escitalopram or sertraline. And you might use mirtazapine if there's prominent sleep disturbance or anxiety. And if it's only really episodic, you could use piontrazodone, but there's really no evidence to date, yet we use it all the time. So that's one case, mild anxiety, mild agitation. Other end of the spectrum is aggression with psychosis. And in that case, the atypical antipsychotics would be supported by expert consensus as first-line treatment. We talked about all the caveats there. The third group would be people who had agitation, aggression with depression, where you might want to start with an antidepressant first-line treatment. But the bottom group, and I've alluded to this before, is the group that we really worry about. These are the hard-to-treat patients. They're disinhibited verbally or physically. They may have sexual aggression. They may be violent. They may have pacing and wandering. They may not be cooperative with ADO care, but there's no psychosis and there's no depression. And then what do you do? And in these cases, we often will try lots of things. We may try with SSRIs if they're not physically aggressive acutely. We may try atypical antipsychotics. We may try one day dronabinol or other cannabinoids might fit in really well here. ECT could fit in well here, again, once we have more data, but certainly this is where we may try mood stabilizing anticonvulsants, including, by the way, gabapentin, which has almost no randomized control evidence, but it has some open label efficacy evidence, and also atypical antipsychotics. My last slide is this one, which is that over the past few years, what we've all begun to realize with the aging of the population and this epidemic of Alzheimer's that are upon us, there is no way we will have enough specialists to care for the population with dementia, and we have to look to alternative models of care. This is an area that our system at Mass General Brigham has been investing in for the past few years in the form of what we're calling the Memory Care Initiative. It's now called the Mass General Brigham, not the Partners Memory Care Initiative. We changed our name. But essentially, this is based on a collaborative care model, which many of you may be familiar with for depression care. And colleagues of mine at Indiana University and UCLA really established this model of care. And what this model is that we pair a nurse practitioner with a social work dementia care manager to impact a sort of cohort of people with dementia and their caregivers, up to 300 people over the course of a year. Dementia care manager plus nurse practitioner, supervising physician, geriatrician, dementia expert, connected in with patients and their providers through the primary care practice. Now with COVID, a lot of it's been done electronically. We collect data in Epic. We're thinking about developing a registry for these patients. We identify them through a registry of sorts and also through referral. And our outcomes that we're really interested in here are really in a few categories. One are clinical outcomes. We want to reduce behavioral symptoms of dementia. We want to reduce caregiver strain. We want to improve quality of life. And importantly, we also want to reduce overall healthcare costs. And we do that by trying to reduce unnecessary emergency room visits and unnecessary hospitalizations. And this team is really the key ingredient in trying to achieve these outcomes. So we will likely have full pilot data completed analysis later this fall. But this has really been exciting to see. We have a grant now from the National Institute of Aging to implement a different model called Crescent using the care ecosystem approach, which we're doing an uptraining of nurse care managers in our practices for people who have dementia within their caseloads. So finally, just in conclusion, when you see older adults who have behavioral symptoms and psychiatric complications, our job is to not throw a label of depression, mania, or psychosis on them, to figure out why. Why is this happening? What are the medical, neurological, medication side effect issues, or psychiatric pre-existing history issues that could be essentially causing these behavioral symptoms in the first place? And then unless urgent and acute, it's really the complete assessment, not just the symptomatic treatment, that really determines the working diagnosis. We always want to intervene with behavioral interventions first and foremost and longitudinally. When using medications, we want to think about, is this depression? Is this psychosis? Does this look like mania? And choose pharmacotherapy based on that, knowing that there's a fairly good amount of data for agitation with SSRIs, a fairly good amount of data with atypical antipsychotics when there's psychosis plus agitation. We always want to balance risks and benefits. And at the end of the day, if patients remain symptomatic, if families are very upset, if the nursing homes and long-term care facilities are up in arms, if we all take a step back and say, what are our goals here? Our safety and quality of life. And we're trying to balance those. Most people will understand it, respect it, and frankly, that's probably the best pathway forward. So I'm going to stop here, stop my sharing. I think I left us plenty of time for questions, and I just want to thank all of you for your kind attention, and hopefully this was helpful. So thanks again. So, Jeff, do you want to?
Yes, here I am. I was waiting for my video to come back. Dr. Forster, that was tremendous. Thank you so much. It's such an inspirational talk and makes me want to go do a geropsychiatry fellowship. So,
excellent.
Yes, thank you. I just am thinking of so many questions. I want to have a cup of coffee with you to ask you about various patients I'm taking care of and wonders that come up along the way. And maybe I'll ask you a couple questions as the chat questions come in, and then we'll go to the chat. So please, everybody out there, put in your questions for us in the Q&A. I see that there's one, and we'll get to that. I'm wondering, first of all, your program that you're describing, the Partners program, the collaborative care model in primary care, it makes me think of many years I worked at nights in the psychiatric emergency room, and a nursing home would bring somebody who's no longer appropriate for care to our emergency room and say they can't come back, and what are we to do? Is there any integration of the kind of emergency rooms or psychiatric emergency room into the model to prevent hospitalization or kind of long-term hospitalization, or I just was wondering about that.
So Jeff, that's a really good question. I just want to also differentiate between the person coming to the emergency room from nursing homes
Yes.
versus the person coming to the emergency room from home-based care where they're getting their primary medical care in the primary care setting.
Mhm.
So our focus currently, in my MGB system-wide work in our system, it's really in the primary care setting. And so the team there, the goal is to not have to go to the emergency room, but then what happens if they are there? And so in the state of Massachusetts, and this may be true in Connecticut, I'm not sure, but after the passage of the, I forget the name of the legislation, but it was during the Obama administration, there was a National Alzheimer's Plan, I think it's called NAPA, the National Alzheimer's Plan Act. There were a number of provisions in there, but within our state, our state plan essentially calls for, and I think we delayed the implementation because of COVID by a year, but strategies to address dementia at all levels in the healthcare system, primary care, ED, hospital basis, starting with education. And now in our state, for any prescribing clinician to get licensed and relicensed, they have to do at least 1 hour, like this would have counted, 1 hour of Alzheimer's disease training of some kind. But we really need to me, that's a big link, is to make sure that we have knowledgeable clinicians in the ED to link back in with the primary teams to see if we can avoid the hospitalization in the first place. Not that it's never necessary, but there's a lot that we can cut down on. Now, when they come from the nursing home, that's another story. So I think whether it's assisted living or nursing homes, if you look at, let's just say assisted living facilities, these are not medical care environments. They're social models of care. They sort of grew out of the hospitality industry. The Hilton hotel chain, for example, started a lot of the original assisted living. So they have wonderful social activities. They're beautiful facilities. They're almost all out of pocket. So they're not even an option for a lot of the population. But even if they are an option, families have to ask, what embedded medical and psychiatric infrastructure is there? Because if you've got Mary throwing something around the room at 2 a.m, they're not going to even have access to a medical team to intervene. They're going to send somebody without even asking questions to the hospital. So what we've been trying to do is to work with memory care assisted living facilities, which is a major growth area in the country. They're being built all over the place, and embed a team there as well with a similar model so that we can try to avoid and prevent some of these things in the first place. Nursing homes, more than assisted living, and I know this is true in Connecticut. I know some of the Yale folks and folks like Alan Siegel's practice outside of New Haven, they've done a ton of work in nursing homes providing consultation in nursing home environments to try to reduce this, but it is and remains a big issue.
Great, thank you. I think I have 10 questions here. I'm just going to just ask you a couple and then I'll turn to the chat. My experience also is that patients with neurocognitive syndromes or dementia of various kinds, there's often like an acute something happens where somebody is suddenly psychotic or agitated, and there's really a change, and the family's not prepared for that in some way. I'm wondering how you talk to families at the time of diagnosis about kind of preparing for the course of dementia and making plans about that, instilling hope, but at the same time helping people to prepare for the kinds of things that would happen. How do you have that conversation?
So Jeff, I'm so glad you asked that question, because to me, making the diagnosis, it's such a critical thing to do, and it's very, very hard for families and patients often to hear it and to accept it. And I find that even though I have my spiel and my way of approaching this, what I have to do and what everyone has to do is realize that every patient and family is at a different stage of the illness, and they're at a different stage of accepting of what's going on. And this is a conversation that's built into our collaborative care model, because if you don't have those conversations, and even if you do sometimes, false expectations, false hope abounds. So the way I approach it is this: instead of thinking about disability and what people with dementia can't do, I focus on what they can do. I focus on ways to maximize quality of life while also assuring safety. Like I said at the end of the talk, those are the two things that we're always trying to balance. And when people ask about prognosis and I try to have a conversation, I break it down pretty simply. I say there are 3 factors that will determine this course of illness. I said, on average, if this is Alzheimer's disease, it runs a lifespan of 8 to 10 years. But look at Ronald Reagan. He was president with some memory symptoms and lived another decade and a half, let's say, or whatever it was. But, you know, you could see people living like the patient I presented with ECT for 20 years after diagnosis. So the course varies, but there are 3 factors that impact course. One is someone's general health, and this is something you can do. So to get to your early part of your point was, if you have a UTI or you've got untreated diabetes or you go into congestive heart failure, all of a sudden you will have not only those medical symptoms, but you will have brain symptoms. You'll have acute brain failure or delirium, a superimposed condition that will lead to an abrupt decline in thinking and memory and functioning. A change in mental status that may or may not revert to where you were before with appropriate treatment of the underlying condition. So the first thing I say is stay healthy. Go to your regular primary care doctor. Let's look for all the medical problems that could be making your memory worse in the first place. Let's get you off medications that might be causing some of these cognitive problems in the first place. And that's another talk, but that's one part of it. The second part of it is psychiatric health, emotional well-being. That was this talk, but essentially we know that if you experience depression, anxiety, psychosis, your course will be worse. Not only will you feel worse and your quality of life will be worse, but your functional status will go downhill more rapidly, and you'll be more likely to be in a long-term care facility. And then the third thing is your environment and what you do every day, and how do you structure and organize your life. Stay healthy with physical exercise, pay attention to nutrition, and keep your brain engaged in meaningful activities that you still may be able to do. And then finally, very importantly, social engagement. I see too many people, I mean, we're going through sort of this epidemic in some ways of isolation and loneliness. We see a lot during COVID, and especially in older adults. But we know that loneliness is associated with bad outcomes, medical outcomes, psychiatric outcomes, and the like. So social engagement is also important. And that's the way I talk about it. And I realize it's only the beginning of a conversation. It has to be an ongoing conversation over time. And I feel like my skills as a psychiatrist are very needed for people with dementia. And I find that the psychiatric approach to this holistic dementia care is very different than other, clinicians who may be expert in the care of people with dementia may have. And I think that's why we're such a critical part of leading the care of these patients.
Yeah, I know of Vivek Murthy citing the evidence that loneliness is equivalent to smoking 15 cigarettes a day, and is not good for our physical health at all. So yeah, so thank you. That's so helpful to hear you talk about that. Your wisdom is much appreciated here. Another wonder I'm having when you're talking about the benzodiazepines and as a class and the problems that they cause. Can you say a little bit about the current understanding of benzodiazepines as etiologic in dementia and where we are with that evidence?
There was that study that came out a couple of years ago. Like many epidemiological studies, people interpret cause and effect when they see that. So I think it raised a lot of questions. But essentially, for those of you who don't know, this was a study that looked at people who had essentially exposure to benzodiazepines and subsequent risk of dementia. And so I think the jury's out on that. It's hard to imagine what the mechanism would be or the pathway. These are essentially drugs that promote GABA transmission in the brain. Maybe they have an effect on glutamate as well. And we know that glutamatergic excitotoxicity can be problematic for neuronal function. But the way I look at it is that benzodiazepines certainly have a short-term effect in people with dementia. But they frankly have a bad effect in all older adults. And so, in 25 years of practicing geriatric psychiatry at this point, I can count on less than 2 hands the number of people I've started on benzodiazepines for more than a dose or 2, because I'm trying to avoid the potential of acute worsening of cognition and the potential, like that article showed, of putting people at risk of dementia down the road. So it's a good question, but I think overall, I would be very cautious about the use of the class of medications overall. And by the way, I would include in that the non-benzodiazepine sedative hypnotics like Zolpidem, Ambien, and so forth.
Yes, yeah. Oh, thank you. Thank you. I'm going to turn to the chat now. Richard Francis is asking a question. What are the promising generation treatments for Alzheimer's? Says Lillian Biogenesis Meds. Yeah,
so let me clarify that question, and thank you so much for asking it, Richard. So this could have been a separate talk, but it's a really timely question. So what I didn't show you in this talk was sort of like our understanding of the neurobiology of Alzheimer's disease and how that's led to what's essentially become now a decade of failed disease-modifying therapy trials. So we all know that when Dr. Alzheimer's discovered this illness back in the early 1900s, the core hallmarks are amyloid beta amyloid plaques and neurofibrillary tangles made out of tau. Until 2006, the only way to visualize these abnormal proteins in the brain was through autopsy or a biopsy, which we luckily didn't do very often. Beginning in 2006 was the advent of PET scanning technology with amyloid tracers, and then subsequent to that, tau tracers. So now, if you want to pay $5,000 out of pocket because Medicare doesn't cover it, and you can go to a PET center, like at Yale, for example, has this, you could get an amyloid PET scan and see whether or not you've got amyloid in your brain. So there are a couple points I want to make before I address the trials. The first point is these biomarkers are critical. And what we will have likely in about 2 or 3 years is a commercially available serum test for amyloid and perhaps eventually tau. So right now, the accessibility and cost of amyloid and tau brain biomarkers is challenging. But what's really interesting is the data that's come up now in the last decade through longitudinal studies like the ADNI trial or the Alzheimer's Disease Neuroimaging Initiative. This was a trial that essentially followed people for decades with imaging and neuropsych testing. And what we've learned from that study and others is that if you present today in 2021 at the age of 65 with symptoms of mild cognitive impairment, you likely have had amyloid accumulation in your brain since your mid-40s. It's probably a 2-decade process of amyloid deposition followed by tau deposition, followed by neuronal death, neurocircuitry changes, neurotransmitter changes, hippocampal atrophy, and then the manifestation of the symptoms. But that amyloid deposition goes back possibly up to 2 decades, which means that if we intervene when people are no longer able to drive or pay their bills in the moderate stage of illness, anti-amyloid and anti-tau therapies, certainly the anti-amyloid therapies, definitively do not work. Eli Lilly and Biogen, I think is what you're talking about, have a number of products that are now in later stage studies. And the 3 most promising are all monoclonal antibodies directed at the amyloid plaque that essentially reduce plaque burden in the brain through various binding mechanisms. They essentially turn insoluble sticky plaque into soluble plaque that can be cleared. The compound that you're going to see a lot in the news in the next 2 weeks or on the day of June 7th is going to be aducanumab. So aducanumab is one of these monoclonal antibodies. Biogen made this compound. It was studied in a phase 1b trial that was published about 3-4 years ago. And what they found in that trial is that definitively this drug removed amyloid from the brain. And there was a hint that it was reducing the decline in cognition and functioning. They then did 2 large phase 3 trials, the EMERGE trial and the ENGAGE trial, with a total of over 3,000 patients worldwide. We were one of the sites. In March of 2019, a year before the pandemic hit, Biogen did an interim analysis of those 2 trials, pre-specified. It's not over the study. Many of the patients were still in the first 18 months of double-blind, drug versus placebo. They broke the blind. They didn't see a difference. They stopped the study. They didn't release the results. They went back and forth with the FDA. In the fall of 2019, a few months before COVID broke out, they said, just kidding. We actually reanalyzed the data. And that if you look at these data separately, and one of the studies is uniformly positive and the other study is uniformly negative. But if you look at the second study that was negative, what you find is that they stopped the study early during this pre-specified analysis. Not enough patients got to the full dose. Turns out that it's a real true dose response effect here, both in terms of amyloid removal from the brain and slowing cognition and functional decline. So they made a case to the FDA and put it in front of the FDA's advisory group in November of this past year. And they said, we think this drug is approvable based on efficacy, when you include the people who got to the highest dose, and safety. And the advisory panel voted 11-1 to not support approval. You probably saw that in the news. The FDA has until June 7th to analyze all that data and subsequent data from the follow-up study where they redosed the people who came off the medication, and they're now in the EMBARK trial. And we're following 6 of those people at McLean. So on June 7th is the date by which the FDA has to make a decision to approve or not, or to say, we're not going to approve and we want to see more data. If this drug is approved on June 7th, and I don't want to make any bets, but I would say most experts feel like it may not be approved because they want to see more data. But if this drug is approved or some other drug down the road, we're going to have a major change in the way we think about treating Alzheimer's disease. Number one, we got to find people earlier for the drug to have an effect. People not in specialty settings, not no longer able to drive or pay their bills, but rather in primary care, who are either very early stages of mild AD or in the MCI stage of illness. That's really going to be the sweet spot for a drug like this. So screening tools will be important. Cognitive screening as well as serum amyloid screening will be important. Genetics will probably one day be important, but we're not there yet. The two other drugs are both promising candidates. Both had positive phase 2 trials. One is Eli Lilly's drug, donanemab, that's now in a phase 3 trial. And the other is a drug, BAN2401, that's an Eisai Biogen drug, which is now in a phase 3 trial. So there are some promising candidates out there, more to come. There was a couple of drugs are anti-tau drugs, and the jury's still out on their efficacy, and they're only in phase 2. So that's a quick overview. And then should we do that last question there?
Yeah, but thank you for that. That's very promising.
Yes.
And hopeful. Sure. So Ethel Schatz writes in, with an aging almost 90-year-old patient with Alzheimer's disease, how do you distinguish that he may be in the dying process when he displays apathy and sleeping almost all of the night and day from deep depression?
Another very astute question. So I think a couple principles here is, if the symptoms that the person exhibiting is apathy and hypersomnia, essentially, excessive daytime fatigue and sleeping, go back to the basics of what I talked about. Why is this happening? This could be the underlying dementia process running its course, of course. It could be that. It could be an intervening medical problem like an infection or a new medication that was put on board. So again, go back to the principles. But if you want to differentiate depression from apathy or depression from hypersomnia, one thing you could do is the Cornell scale for depression and dementia. This is a scale that was developed by George Alexopoulos and colleagues a couple decades ago or more, and it essentially allows you to tease apart apathy from depression by interviewing a caregiver and a patient to try to come up with a combined score. But it can often, in the practical world, be very difficult. In a person like this, assuming there's no other medical driver of this syndrome, one approach is to use psychostimulants. Stimulants would help with all three problems, regardless of cause. Again, assuming there's no acute medical issue going on here. If it's apathy, if it's hypersomnia, if it's depression, you might see an acute response to methylphenidate at a dose of 5 or 10 BID. And that would be an empiric trial, safe, generally speaking, and worthwhile considering, for example. But it also, this question highlights how important end-of-life care conversations are from the very earliest stages of the illness so that the person can be involved in their care. Because what comes up in a question like this is, where is the quality of life here? If it's depression or even apathy or even hypersomnia, it still may be treatable. But there may be situations where you get to the point where the benefit of ongoing intervention is outweighed by the fact that the quality of life is so poor. And so hospice was never really developed or designed to think about Alzheimer's care. It was really a cancer care model. And so I think there's thankfully some great research being done now with the use of palliative care in dementia and hospice in dementia, but this is an area that needs a lot of help and work right now, actually. And so I think the approach here in all situations in dementia should be a palliative one, again, balancing, quality of life and safety. There may be some empiric trials that are relatively easy to do, but I think the big picture conversation with family and goals of care is most important.
Great, thank you. So Dr. Forster, I have one more question I'll ask you, so I don't see any more in the chat. You mentioned exercise. How much exercise do we need to keep our brains healthy? Can you say a little bit about your knowledge about that?
Yes. So of all the studies that I've reviewed in the last 5 to 7 years on healthy brain aging, it's really the exercise data that to me is the most encouraging and promising. Some of this comes from animal models and some of it comes from data with humans, but there seems to be a protective effect on reducing the risk of Alzheimer's disease with aging. And so how much is too much or enough? I think the best data is probably that it's some amount of exercise that's like aerobic exercise where you get to about, X% of your maximum heart rate, like 70-80% of your maximum heart rate, 30 minutes, 3 times a week, something like that. So for some people, that's a brisk walk, and that's fine. For other people, it's a jog. For other people, it's a stationary bike. For other people, it's yoga or whatever it may be, but it should be something. And I will tell you that there's probably an effect as well on, the mental health benefit of exercise with this as well. So it's for people with depression or even dementia in later life, that the beneficial effects on calming one's anxiety levels or improving mood is not insignificant with regular exercise. So I think that's one of the reasons why when people lose their ability to walk and ambulate, they then forget that they can still exercise. But I do think that often leads to a sort of a vicious downhill cycle. But I would say that that's a rough guide. Some people also talk about the beneficial effects of weight training as well, but some combination of basic weight training and 30 minutes of aerobic exercise 3 times a week is what most would recommend. It doesn't have to be training for long distance running. It doesn't have to be anything like that. And routine is important. The last thing I'll tell you, and this is a trick I learned because I do a lot of exercise and love it and feel like, frankly, that's my mental health trick to getting through the day, is pairing it with social engagement. First of all, you're around other people, so that's a good thing. Second of all, they will motivate you to get out of bed in the morning or get together later in the day or whenever, so that this is one of the reasons why the Peloton craze has taken off, is because they paired exercise with social engagement, especially during a time of a pandemic. But regardless, getting a group together to do this, whether it's in long-term care at home, I think is an amazing combo. And it's something we don't think about enough in psychiatry. And frankly, we should be prescribing this for our patients.
Mm-hmm. Yeah, I've heard of actually people doing that, writing that down on.
I do that.
You do that, yeah.
Absolutely. And by the way, if people can afford it, some type of monitoring device can be another form of not only assessing how they're doing. So I didn't even get into the use of technology for assessment and management of dementia, but a Fitbit where you look at just steps and sleep can tell you so much about what's really going on with your patients or your loved ones, that it's certainly worth the investment. And I think we need to learn more about how these, what we call them, deep phenotyping markers can really help with better assessment of our patients.
Great. Jane Duncan just chatted in. Can you say something in the last minute or two here about alcohol and alcohol abuse and its effect on Alzheimer's disease?
So when I think about risk factors for Alzheimer's, I think about the modifiable and the non-modifiable risk factors. So in terms of the non-modifiable, it's essentially getting older, age, and family history, genetics. But there's way more modifiable risk factors, and alcohol is one of them. 3 of the modifiable risk factors are cardiovascular risk factors. So if you think about it in this way, anything that causes heart disease can cause Alzheimer's disease, and that's hyperlipidemia, diabetes, hypertension, obesity. If you modify those metabolic risk factors, you can really reduce the risk of Alzheimer's disease. The 2 psychiatric ones are depression, which is an independent risk factor for dementia, and alcohol or other substance use. So there's a clear link there. People are more sensitive to the effects of alcohol as we get older. And there is a condition we call alcohol-induced persisting dementia for those people who abuse alcohol tremendously. But even if it's not abused or used consistently over years, it can have a deleterious effect on cognitive function with advancing age. Korsakoff syndrome, which is an acute manifestation of alcohol intoxication, and has all sorts of assessment and treatment implications, is different, can lead to a chronic condition of dementia. But more often than not, the worry we have is the alcohol-induced persisting dementia in people who really are heavy users.
Great. Dr. Forster, thank you so much for all of your wisdom and for sharing that with us today. Cheryl, thank you so much for bringing Dr. Forster to us. Greatly appreciated. And for, so thank you. And thank you everyone for joining us. Just as a reminder, as we close out today, you'll see a survey pop up in your web browser. So look for that in order to get continuing education or CME credits. So thank you everyone for joining us. I see we're right at the end here. So thanks again and see you next time.
Thanks everybody. Bye-bye.
Bye-bye.